Okay, Assalamu alaikum to everyone. So today we are going to start our SBA course at the PrepXperts Online Academy. So most of the people were from Belgium. They know me. I am part of the London Global Emergency Medicine Program faculty member, and I'm also part of the PrepXperts Online Academy. I am doing mentorship here for the MRCEM primary and intermediate courses. I have recently completed MRCEM primary course yesterday, and we are going to start the MRCEM primary crash course from tomorrow. And we are starting the SPA course today. So I have selected uh, 3 sessions. One session on SBA preparation, how should you prepare? And the other 2 sessions were sample session, that how will we teach in the MRCEM SBA course. So if you are enrolled with us, that's good. And if you are not enrolled, if you or any of your friend is going for MRCEM SP exam, you can recommend if you feel that it would be helpful. And the other thing I have already mentioned that no one can pass you unless and you become able to pass. Okay, until you have a passion to pass, until you study hard, until you study smart, no one in the world can able to make you pass the exam. And it's you who will make yourself able that capable to pass the exam. That's the most important thing. Only what we can do, we can only tell you that you should study this way, you should focus on this area, and how the question can be asked, and that's the important thing what we can teach you. You have to remember yourself, you have to revise many times, because if you are not working in NHS system, then it's very difficult to pass HB exam, because in primary means things are same. Like if there is a short fracture, everyone know that it will be a radial nerve fracture. If there is any function of muscle, it will be same in UK, it will be same in everywhere. So you have to only grammar it and you have to pass it. You have to get. But when it comes to the clinical knowledge, then it comes to the guidelines, because what we are practicing in the emergency department is mute. Okay, what we are practicing in emergency department, that is a totally different practice in Asian countries. Either it is India, it is Bangladesh, either it is Pakistan, from either it is Sri Lanka. That's different practice. Other than the some well-established systems, they are following the international guidelines. 90% hospital, they are not following the guidelines. So that's why it's difficult to pass, because when you are practicing, if you are seeing one patient on daily basis, it becomes your routine that when the patient have come to the emergency department with any upper limb injury, you know that how will you approach the patient. But if you are not following, as in our emergency department, most likely we are doing a medical emergency, if any emergency department, any patient come with upper limb trauma, we only say go to the orthopedic department. We don't see it. If we are in the orthopedic department, we don't see the medical emergencies. If we are in the neurosurgery training or anything, then we don't see the medical emergencies. If we are in a medical emergency department doing the internal medicine, then we don't see the patient. So how will you will remember these things when you will see the X-ray. Whenever you are reading, go on to the Google the X-ray, see it, watch the videos, make your own notes. As I have planned, I will complete whole course in 3 months. Inshallah, if there is not any obstruction, any hindrance in the course. due to my schedule, but I will try to complete all course in 3 months till 10 July. We will complete the course of SPA. So in 3 months, because 5 months left, you must make your notes. In 3 months, everything should be ready. You should have revised all course and crammed it. In last 2 months, you have to revise it. I would say how we passed the exam. Like my friends and we revised the course approximate 3 times. If you will revise it 3 times, you will pass it, but with the edge. If you will revise it 4 times and smartly revise it. Why is starting the trauma? Because most of the people who are not working in surgery department. They don't know about the trauma patient, how to deal them. So that's why I'm starting from trauma. The other thing I will do the resuscitation, and these two parts have the maximum MCQs in the exam, 30 plus 40, 70 MCQs. So they have a maximum part. So I have explained everything in the SPA session. So today I am going to start the upper limb injuries and idea. I will give you the idea, and then tomorrow I will not do any session. Day after tomorrow, I will complete the upper limb. So that's how I will give a gap between the session. So what I have taught you, you can study yourself. So you can follow the pace of course. And if you will follow the pace of course, you will complete the course in 2 to 3 months. If you will not follow, you will not complete it, whatever you will do. I hope you have understood it. So today our topic is upper limb injuries. So first of all, I teach you that how you will approach the patient with orthopedic trauma in the emergency department. Any patient who is coming to you with the history of trauma, you will follow the ABCD approach. You will check the airway. If the airway is patent or not, you will maintain the airway. You will not see that patient is having any trauma on the legs, anything, you will not follow it. But if there is any catastrophic hemorrhage, mean amputation, then you will control the bleed. That is ATLS protocols. You will follow the ATLS protocol. Okay, control the bleed. We will study in, and I will teach resuscitation, especially that ATLS trauma from the ATLS manual of the trauma council from the UK. I have got it. The PDF I am studying and making notes. Then I will teach from there. So you will follow the ABCD approach, then you will go for the breathing, respiratory rate, pulse, oxygen saturation, then you will see the trachea, breathing, respiration, any sounds. That's how you will do the ABCD. Then you will then comes the C. In C, you will see the heart rate, uh, capillary refill time, blood pressure, pulsal pulses. Then comes the, if it is trauma, then you will in the C, then you will look for the any any catastrophic bleeding like abdominal injury, any urethral injury, any major injury, femur fracture that is causing the hypotension, then you will control it. Then comes the D, you will see the GCS, pupils, any signs of lateralization, and then the blood sugar. Then the E and E, you will see everything. Any, you will expose the patient, you will see any spine fracture, anything else you will see in the E. Then comes the secondary phase. So that's how, when they will give you the trauma patient, then you have to follow this approach. Okay, any trauma patient. And then the secondary survey, what will you do? You will in between, you will also call, if needed, you will call the specialty. If it is high impact trauma, you will call the trauma team. If it is surgery related patient, you will call a surgery, neurosurgery. That's how you will call the help. That's very important. So you will perform the focus history. What was the mechanism of injury? When it happened, how much the force was involved? It was from a height. How much was the height? It was low impact, high impact trauma. That's how you will know about the forces involved. So you will do the full head to toe examination, looking for deformities, swelling. You will look for the open wound, tenderness, crepitus, neurovascular compromise. Okay, if any of these are neurovascular compromise are present, any open wound is present, that will change your management plan. So that's very important. When you are reading the scenario, always look for these things. If there are any open wound present, if there are any neurovascular compromise is given, if there are any crepitus is given. So if the airway is compromised and they are given the anterior shoulder dislocation, you will not manage the anterior, you will manage the airway. Okay, if GCS is low and they have shown you the anterior shoulder dislocation, you will not go for the anterior shoulder dislocation. You will not go for the any clavicle fracture dislocation. You will maintain the airway. That's very important. Other thing, initial management. So patient is stable. You have done the ABCD management. You have done the secondary survey and know if there is any fracture. Okay. So if there is any bleeding, you will control the bleeding. So first, whenever patient comes to the emergency department, so first thing you have to maintain the pain. That will give a big relief to the patient. So you will do the pain management. Initially, you will do the pain management, offer the ABCD management and Candy survey. You will do the pain management and neurovascular assessment. That's very important. You will check the circulation, sensation, motor function. When if a patient needs immobilization with the splinting, anything before and after splinting, you will check the motor function. If you are applying splint on the hand, you will ask to move the fingers if they are moving or not, so that you can assess. Other thing, investigation, x-rays, if needed, you will do the x-rays, always do the anterior posterior and lateral views of the injured area, and you will ask for the joint above and below. That's very important. If needed, if there is hairy impact, if any indication of CT, then you go for the CT, but that will depend only on the indications of CT. Other thing that's important, definitive care. So you will, if patient has come to the emergency department, there's a difference between the developed countries emergency department and our underdeveloped countries emergency department. So they are working as a single unit. So emergency physicians have to manage everything. So if patient has come with anterior shoulder, you can reduce it. So you will reduce it after procedural sedation. So if it needed, so you will reduce either before. Always remember, when you are going to do any procedure in the emergency department, before that give the sedation or analgesia. Procedural sedation is very important. So give the tetanus prophylaxis, antibiotic for open fracture, orthopedic consultation if needed. If patient needs any urgent intervention, you will call the orthopedic team. Either it needs a follow-up, then you will send for the follow-up. So that's how you will manage for the orthopedic consultation. Either patient needs a discharge, then you will give a clear instruction for the discharge. So these things are very important, and that will be assessed in the OSCE exam. To whom you are going to admit the patient, to whom you are going to discharge, to whom you are going to keep for observation, and you to whom you assess that a patient needs urgent intervention, to whom patient needs follow-up. These are very important because you are going to be a registrar. So these things are very important in the emergency department as a registrar at MRCEM level. So next come the special conditions, open fracture, compartment syndrome, neurovascular injuries, pelvic fracture. These are emergency when you require the immediate intervention. I hope you have got the whole concept, how you are going to assess the patient who is coming to the emergency department after trauma, orthopedic trauma, or any trauma. So now comes the in the upper limb trauma, we will discuss the clavicle fractures and shoulder dislocation and humeral fracture today. And from day after tomorrow on Saturday, we will have session on elbow injuries, and then the hand injuries. Okay, that's how we will. Okay, first come the clavicle fractures. So what you see in this clavicle fracture, what type of clavicle fracture is this?
Sir, this look like the distal most portion of the clavicle is chipped off in a form of a wedge. This is what it looks like.
Okay, good. And what about this?
Sir, this is the initial one-third portion separated absolutely from the distal two-third of the clavicle.
It is 1/3 or middle short fracture?
Middle, sir, middle.
Okay, yeah, it is middle short fracture. Okay, so most common is middle short. That's very important. So when how the clavicle fracture? What is the function of clavicle fracture? It links shoulder girdle to the trunk, and it articulates on one side with the sternum, on distally with the acromion. Okay, so that's are the function or sports how the clavicle, what is the clavicle doing it here. So clinical feature, there will be tenderness, limited range of motion. What will you do? We will do the 45-degree cephalic tilt view X-ray. That's very important. And if there is any high impact trauma, then we will go for the CT. If proximal 1/3 of fracture involved, then there is chances that there can be any chest trauma, pleural cavity trauma, that any sternum injury. So then we will go for the CT. But it depends on the impact, trauma, and condition of the patient and everything. So this is distal. So how I got this? I googled the distal clavicle fracture. Whatever the photos I found, images, I have seen it. So you have to do it, because whenever the examiner is making uh, the MCQ, the short based answer, they will Google it, and you will see a very low quality images in the exam. Who have attempted, they know it. So that's where it's important that you may know every type of X-ray. You can read it. So that is middle shock fracture. So what's important in it? In distal clavicle fracture, there can be types. Type 1, but these are least common things that because most likely but they can ask about the type 1, type 2A, type 2B, and type 3. But the management of these type, they can give that type 1 and 3, they can ask about the management. So that's very important. But I will teach you that type 1, that distal to the clavicle ligament. Okay, but the ligaments are intact. That is type 1. That you can see in it that it will be if there is a fracture distal to the cracoclavicular ligament, but the ligaments are intact. Both ligaments are intact. That is distal. Okay. Whenever there is no injury to the ligaments and there is no tear to the ligaments, in any case, either we are going for the clavicular fracture, any fracture like this, that means we have to manage the patient conservatively. If there will be any tear, if there any case, if there is any neurovascular blockage, if there is a multiple fracture, there is a open wound fracture, then we will involve the orthopedic team. That you must remember as a general rule, but that can be changed in some conditions. So distal to the cracoclavicular ligament, so that is type 1. For type 2, so that will be medial to the cracoclavicular ligament. Okay, that will distal, and if it is medial to the cracoclavicular ligament, then it is type 2A. But type 2, so there can be type 2 and type 2B. So in type 2, there will be medial to clavicle, and there will be upward displacement of the clavicle. There will be upward displacement like this, upward displacement of clavicle. And the type 2B, that will be between the cracoclavicular ligament and coronoid ligament will be torn, and trapezoid will be intact. That's very important. Coronoid ligament will there will be tear in coronoid ligament and trapezoid will be intact. So that is type 2B. But type 3, that is intra-articular AC joint fracture between the joints. That is so because in type 2, either it is type 2B, type 2A, so there is involvement of the ligaments. That's why we will need a surgical intervention. But for the type 1 and type 3, we don't need, we will only apply the sling immobilization. So which type of sling we apply in the clavicle? That's very important. Which type of sling we apply? That's this question. Yes, figure of 8. Dr. Knapp have already attempted, so that's good. You will pass this time. Okay, so figure of 8. That's very important. These question will be asked that if there is shoulder dislocation, what cost yeah, or sling immobilization you will apply if there is a shaft of humerus fracture, if there is proximal humerus fracture, if there is supraclavicular fracture in hand. That you must remember that which cost you will, how will you immobilize, because immobilization is the job of emergency physician. So first you have to immobilize. Okay, so that's very important. So how will you will apply the figure of 8 brace, but for the middle third clavicle fracture you will this is a common fracture, middle third, and you most of the time you manage conservatively. You will apply the sling or figure of the 8 brace. That's very important. For how long you will apply the figure of 8 and you will immobilize 4 to 8 weeks. That's also very important. Okay, you must remember it. How long you will apply it, because these type of question they will ask. This is a one word, but they will ask this question that patient has come to the emergency department and they will show you the x-ray, and whenever you will see this x-ray you will be happy that I know the diagnosis, but when you will read the options you will be worried because there will be no option given about the diagnosis. They will ask that patient has come to you and you have applied SHO has applied the figure of 8, and patient want to know when he have to remove it. Either they will be given patient you have advised the patient to remove it in 2 weeks, in 4 to 8 weeks. Either you don't need to apply it, you need to remove it. That type of question they will give. That will be confusing. So always there will be two options which will be looking correct to you, but you have to choose the best option. We will discuss the MCQs on Sunday. When we will complete the upper limb trauma, I will send the MCQs in the groups and we will discuss about X-rays, MCQs. That's how we will go with this course. So length 4 to 8 weeks or until the pain resolves. Severe distress may require orthopedic referral. So there will be proximal third clavicle fracture. In this case, most of the time proximal third clavicle fracture happens due to high mechanism injury that can involve the intrathoracic trauma. So if there is a proximal third clavicle fracture, but it depends if patient is having any sign and symptoms. First you will go for the x-ray. If you find anything, then you will go for the CT scan. And management, you will immobilize and refer to the orthopedic within 1 to 2 weeks. That's very important. Okay, if you are confusing anything, if as I have mentioned that you must have the RCAM membership, you can go out the RCAM and you can read the management. That's very important. Okay, so on RCAM learning you must make your own notes, different resources, and I have also mentioned trauma is written very good on the OM in terms of management. How will you approach the patient, what you are going to do next, what you do next. So that's how So in these slides, what I have told that what are important approach to patients, and then the cephalic view X-ray you will do distal clavicle fracture, middle clavicle fracture, type 1, type 3 you will manage conservatively, type 2 you will require the surgical intervention, middle third clavicle fracture you will apply the figure of 8 brace. That's very important. How long? 4 to 8 weeks. Either the until the pain resolve. These 2 points are very important. Okay. If there is a severe displaced fracture, then you will refer to the orthopedic for surgery. If it is a proximal third fracture, you must suspect there, you must assess the thoracic cavity, anything related to chest to know that is there any associated intrathoracic trauma. If needed, you can go for the CT scan to confirm. Management, you will apply the sling embolization and you will refer to orthopedic within 1 to 2 weeks. So scapular injury. Scapular injury is very less common, and it also happens when the patient had a history of fall on the outstretched hand, if there is a high impact trauma, and as scapula is behind, and there can be involvement of any other associated injury, lung, thoracic, shoulder girdle. So isolated scapular injury is very less common. That you must remember. So what are the clinical features is very important. This question have been asked many times in different anterior shoulder dislocation, posterior, any other that patient they will give you this X-ray or they will give you this X-ray. Like you can see that is scapular blade fracture. Here you can see an arrow that is showing the scapular fracture. So they will give you the X-ray. So you will know the diagnosis, but when you will see the option, they will change it. Okay, so they will give that how the patient arm will be held. What are the clinical features when you are going to assess? So the clinical feature arm will be held in adducted form. So that's very important. Arm will be held in adducted form in scapular injury. That's very important. Arm will be held in adducted form. The diagnosis, you will do the chest CT to have the comprehensive assessment, scapular Y-view X-ray, management always first in every case. It depends that I also discuss there is a glossary given on the RKM website. I should share it now, either I will forget it. I'm going to share it now. Either I will forget. That they in this file it is written that what the RCAM mean by initial management, what they mean by definitive management, what they mean by next step, what they mean definitive investigation. That's the all glossary R terms are given there. So that's very important. I discussed in my SPS session. So, I have shared in the group of intermediate. Okay, you can see glossary of terms used in college examination. Okay, these are very important. Slide. Can you see the slides? Oh, yes. Okay. Okay. So we were discussing about the scapular injury. So when it comes to the management, okay. So in management, that now the definitive management, okay, it involves everything that you have to make the patient pain-free, you have to immobilize, you have to do the neurovascular examination, you have to do the ABCD. That involves everything in management. That is the broad term, okay. So definitive thing is very different thing. Initial, but initial means initial and immediate. That's also very different things. Okay, and immediate, what you are going to do now, right now, what you are going to do. If patient is having GCS 7 and patient is also having the scapular injury, they ask you what is the immediate management. What is the immediate management? If GCS is 7, that is intubation. Immediate management is airway control, airway management, and that's very important term. You must remember it. Okay. So management initially, what will you do? First, you will immobilize, apply the sling, ice, analgesia. Then you will follow the in the orthopedic department. So these are the X-ray. You must Google and you must know it and you must revise it. I have mentioned many times that I have shared the videos and LGM intermediate groups, and I will share with the MRCM expert intermediate group, uh, PrepXpert intermediate group, that how we used to study. We used to send many points daily on daily basis. We used to send MCQs. We used to send X-ray. We used to discuss. That's how. When you are discussing, if you think you will pass on your own, it would be very difficult. If you will discuss the things, that would make easy for you and for others. So these are acromioclavicle joint injury. That's these are also very important. First you can see, you can remember that when you have applied the force and anything, when you apply on anything, there will be a stretch. So first it will start from stretch, that is type 1. Then there will be a rupture or tear. Okay. So a partial rupture. So first it will be stretch. Anything when you are going to tear it, first it will be stretched. Then there will be partial tear, rupture. Then there will be complete rupture. So that's how you can remember type 1, type 1, type 2, and type 3 for acromioclavicle joint injuries. So first there is a stretch. When you are pulling it, there will be stretch. Then there will be partial rupture. Then it will be a complete rupture. Okay. So I have told whenever there is, because complete rupture have happened in 3 and after that 4, 5, 6. So there we will need intervention, surgical intervention when the rupture have happened. But there is no rupture, there is stretch, partial rupture. So in these both cases, we will only manage conservatively. Okay. I hope you have got it. The other thing that so you can raise the pointers. Yeah. So you can see in type 1 stretch, in type 2 disruption, in type 3 acromioclavicular and cracoclavicular ligaments are ruptured. Okay. So in type 4 there will be rupture of all supporting structure, means the ligaments, all ligaments will be ruptured, and so clavicle will be displaced posteriorly. That's very important. And fourth, that will be displaced posteriorly. here you can see that it will displaced posteriorly in type 4, okay, and inferiorly you can see under the skin in the type 5. That's how you can remember. So how will you manage? I have already mentioned that in type 1 and type 2, as there, first of all, initial you will do the ice, apply the ice, analgesia, and immobilization in type 1, type 2, and you will do the conservative management. Okay, you will apply the vaccine, but for the type 3, 4, and 5 and 6, you will refer to the orthopedic for the surgical repair. That's very important. Okay, now comes the anterior shoulder dislocation. Shoulder dislocation that have three types: anterior, posterior, and inferior shoulder dislocation. Okay, so first you must know the normal shoulder. On X-ray you can see that is normal shoulder. Can you differentiate between two X-rays? Yes. Okay. So right one is normal, okay, and there is a shoulder dislocation on the left one. So normal, we will see that you can see there is a humeral head, okay, inside the glenoid cavity, that is fixed inside the glenoid cavity. Above this is a chromium process, and that is shaft of humerus, okay. On the X-ray, you can see the ribs, and there is the lateral border of scapula, body of scapula. This is that will be that is difficult to assess. In here, you can see that is body of scapula. Okay, you can see the coronoid process, and this is the clavicle. So, chromium process, humeral head, that is body of, and that is glenoid cavity, and lateral body of, border of scapula, humerus. So that's the normal. Okay. But in this X-ray, you can see how it is anterior. So that is how it is dislocated posteriorly, inferiorly, or superiorly from the X-ray. What you are seeing from here, it has gone above, it has gone down, it has gone posteriorly. How it is dislocated. Yeah, you can see that it has moved inferiorly. Yeah, that from here it has moved downward. So that is the anterior shoulder dislocation. Okay, so you can see that is not inside the glenoid cavity. Okay, that is the space you can see, and that has moved inferiorly. And what you can see on the X-ray, arm is adducted or abducted. like this. Abducted. Okay, so that's very important clinical feature. Whenever that also have been asked in the exam, that arm you can see it has moved downward, so arm is abducted, mean away from the body. Okay, so that's also important clinical feature. From the X-ray you can also see. What's that? Okay, so the next where the slide is, this is the slide. So you can see that most commonly the result of forceful abduction, extension, external rotation of shoulder, arm abduction, arm will be abducted, externally rotated. That is the important clinical feature. Patient will be unable to touch the control of the shoulder. That's the important clinical feature. And these will be opposite in the posterior shoulder dislocation. And as I am saying that these clinical features will be opposite in the posterior shoulder dislocation, but the clinical feature you will see in the posterior shoulder dislocation, arm will be in posterior shoulder dislocation. What will you see in posterior shoulder dislocation? Arm will be okay. Arm will be adducted. So that's very important. So in the anterior shoulder dislocation, arm will be abducted, externally rotated, okay, and you can anteriorly palpate the humeral head. So that's how you will clinically also diagnose the anterior shoulder dislocation. Recently, Dr. Webb have posted, so he can also tell in the chat box that he was able to palpate the humeral head. If you have seen any patient in the emergency department with anterior shoulder dislocation, you can easily palpate the humeral head. Okay, and patient will, when you will ask to touch the control of the shoulder, he will not be able to move it to the opposite shoulder. These are very important clinical features. In investigation, you will do the AP lateral view. Either you will do the scapular Y radiograph or dislocation. How will you manage? You will do the apply the analgesia, immobilize, rise, and you anterior shoulder dislocation. You will do the reduction. Okay. What are the reduction techniques that are very important? Before that reduction technique, you will check the pulses, sensation, and what are the reduction techniques? These are very important. So reduction technique, modified Cochrane's method, Stimson technique, modified Milch method, Ingham technique, Paris technique, and whenever you are doing any procedure, before that, what will you do? You are going for the procedure reduction, modified Cochrane's method. What will you do? They will give you this type of question that patient has. Yeah, you will do the procedural sedation. That's very important. Okay. X-ray before reduction, X-ray, procedural sedation. You will shift the patient to the resuscitation area. Okay. Monitored area. There, because you are doing the procedural sedation, patient must be in the resuscitation area, or the cardiac monitor should be attached, and it should be difficult intubation trolley because you are giving the procedural sedation. And the other thing that's important, I will share the notes about the procedural sedation. How many person should be there? That's also very important. Either other thing that's important, are you able to do the reduction? Are the doctor you are capable of doing this or not? That's very important. So before any procedure, you will give the procedure sedation, and then in the reduction technique, modified Cochrane's method, Stimson technique, Cunningham technique, these are very important. And this reduction technique is also very important in the OSCE exam that came in my exam. Okay, so that's have been asked many times in previous exams. So that's reduction techniques are very important. Modified Coaches method. Okay, that is without any traction. You will not apply any traction force. So that's why it is called uh, external rotation method and without traction method. This question have been asked that which method reduction technique is without you do the reduction without any applying any traction. So that is modified Coaches and Cunningham technique. In both, you will not apply any traction. So how will you do it? You will ask the patient to flex the arm. First, you will adduct the arm. Slowly, you will adduct the arm and you will ask the patient to flex the arm at 90 degree. Then you will externally rotate. Okay. Flex, externally rotate, then internally rotate. So that's how you will do the modified Coaches method. That's very important. What's that? Okay, next is the Stimson technique. In Stimson technique, you will place the patient in prone position and you will hang the arm down at the edge of the at the edge of the bed, and then you will apply the weight for 20 to 30 minutes, and that's the traction technique. And the modified MITS method, you will abduct the arm to 180 degree. Okay, abduct the arm to the 180 degree with simultaneous pressure on the humeral head, and that's how you will apply the opposite in on the opposite side pressure. That's how you will reduce the anterior shoulder. In Cunningham technique, you will do the massage of the muscles, deltoid, tricep brachii, and trapezius. These three muscles you must remember. I'm sure about deltoid and trapezius. By either, I think it is tricep brachii and bicep, but tricep brachii. You can confirm it. So in this Cunningham technique, you only do the massage. So anterior shoulder dislocation, what can be the complication? That's very important. Injury to the axillary nerve. So most of the time they will give you the X-ray that will be showing anterior shoulder dislocation. And in the question, they will not ask about the injury to the axillary nerve. They will give the function like patient can't do abduction, patient have loss of sensation, in the lower deltoid, patient can't do the lateral rotation part because axillary will also supply the trees minor. So that's how either they will give the trees muscle and trees minor muscle, and they will ask which muscle is affected. So that's how they will give the confusing statement. That's what the SPA exam is. They will not give the state. Yes, there will be straightforward question, but that would be only 30% question or maximum 40%. That will be simple question, easy question. You must not make a mistakes in these questions. 30% will be intermediate, 30 to 40% will be very difficult exam. So that's how you must not miss the easy and intermediate question. So in complication, injury to axillary nerve, injury to axillary artery, rotator cuff injury, but rotator cuff injury most likely occurs due to greater tuberosity fracture. That you must remember. And there can be any comminuted fracture and associative fracture, humeral head fracture, greater tuberosity, and clavicle and glomerular fracture. And there are hill sac lesions and Bankart. Hill sac lesion you can remember from that hilly area of the humerus, mean on the humeral head there will be a compression fracture. So that's called the hill sac lesion. And the Bankart lesion mean the bank of anything, mean it is a part you can see that avulsion of the inferior glenoid labrum, So that is the bank area. So it is fracture avulsion, that is called Bankart lesion. So what you can see in it, that's the easy thing. They will not give what that's the pointer. That's very easy. Light bulb sign. They will not give it. They will give it this like X-ray. Okay, that is also light bulb, but a very dim light bulb. Okay, so they will give you dim X-ray. So that is all to light bulb, but you must remember these X-ray. You can see that light bulb sign, and there is a vacant glenoid site. So that's the posterior shoulder dislocation. That will be showing the light bulb sign. Another thing, again important, that they will give you this X-ray, then they will ask about the clinical feature. What's the patient? That question was asked in my exam too, I think. That they asked about the clinical feature. Like this question was that like this: patient will be unable to externally rotate, abduct the affected arm. Okay, so patient will be unable to externally rotate and abduct the affected arm. How the patient arm will be? It will be adducted and internally rotated. So that will be clinical feature, adducted and internally rotated. But what will patient not do? Either he will not be able to do, that is the opposite thing, external rotation and the abduction of the affected arm. What will you do? You will do the AP view, humeral head and the bleed profile will show the light bulb sign we have discussed. A lateral exit profile management, you will reduce under the sedation procedure is very important. We will perform the traction, counter traction method. Okay. You will apply the external rotation to the affected arm and the 90-degree flexion arm will be flexed and you will apply the external rotation. So that's how you will apply traction and counter traction, and simultaneously you will do the external rotation. That's how you can reduce the posterior shoulder dislocation. Other important, that is inferior dislocation. Either it is called the lexitio erecta. That's also very important. That's happened due to hyperabduction force. If you are pulling something and you are hyperabducting your arm, then this injury can happen, and that is inferior dislocation, which levers the neck of the humerus against the acromion process. Clinical features: arm would be held abducted above the head. So arm will be held abducted but above the head. So that's very important. Management, we will treat as anterior shoulder dislocation because in this arm is also affected, and we will have follow up with the orthopedic department. So proximal humerus fracture, that's the most common fracture of the proximal humerus, include a surgical neck and greater tuberosity, and the proximal humerus that can be greater tuberosity or the proximal humerus fracture include the surgical neck fracture or the greater tuberosity fracture. Okay, these are very common. So patient will present with the pain, swelling, tenderness, or will be held in adducted form. And diagnosis, you will do the AP and axillary radiograph. What injury you will see in the greater tuberosity fracture? That's a very common question in SBA about the rotator. That will be rotator cuff injury associated with greater tuberosity. Okay, so this is a very common question in OSCE and SBA too. So proximal fracture you will treat depends upon the nerve system classification. Okay, and if it is only the one part fracture, then you will immobilize. Okay, with collar and cuff spot. This question have also been asked in the past exam. Collar and cuff. You will apply the collar and cuff. If it is only one part fracture, then you will apply the collar and cuff, analgesia, and immobilize, ice, and orthopedic follow-up. So if there is more than one part fracture, cumulative fracture, multiple fracture, then you will refer the patient to the orthopedic. Complication, axillary neurovascular, brachioplexus injury, surgical neck fracture, rotator cuff injury associated with greater tuberosity fracture. So rotator cuff injury associated with that greater tuberosity fracture, that's very important. So if there is a rotator cuff injury, then you will apply the broad arm sling, okay, and send for the physiotherapy. So these rotator cuff injury, muscle injury, the patient most likely will become with sport injuries like rugby player, football player, they will come with it. So if there is impingement, then you will apply the sling and have a follow-up with orthopedic. If there is a tear in any muscle, then you will urgently refer to the orthopedic. Just give me a minute. Okay. So we were discussing about rotator cuff injuries. So there are six muscle, supraspinatus, infraspinatus, teres minor, and subscapular. They can give the greater tuberosity injury. Then they will ask about any abnormal function about the supraspinatus, like abduction of arm up to 15 degree. Either they can give the infraspinatus teres minor, and they can give the patient is unable to do the lateral rotation of arm. Then they can ask about the muscle injury. Either they can give that the patient unable to do the medial rotation of the arm. So they can give anywhere that they will give that after the injury at the either they will show the x-ray, then they will give that patient unable to the medial rotation of arm. What type of injury is this? Vertebroplasty injury, that they give the what type of muscle it is, what test you will do. That's how in different way they can ask. So you must be ready for every type of question. For supraspinatus, you will do the empty can test. So you will ask the patient to position the arm at the 90 degree in the scapular plane. You will apply the force on the thumb downwards, and you apply the force. And if the patient feels pain, then it's the supraspinatus impingement. If weakness and unable to hold that way, that is a tear. And that is infraspinatus term, Hornblower lift off test. You will ask the patient to place palm dorsum of hand on the lower back. Then you will ask to push against your hand. If they feel pain, then there is the subscapular injury. Then you will also do the knee test. These are very important for the examination of shoulder and also for the OSCE and SPS. This rotator cuff injury is very important. Then the humeral shock fracture. So this is the last topic we're doing. Clinical feature, localized tenderness, swelling, and there can be the isolated humeral shock fracture. There can be the uh, different fracture. So it management will depend on it. So on X-ray, there can be comminuted transverse or spiral humeral short fracture management. You will apply the POP use lab. That's very important. Okay. So as use lab, because it is from fracture the middle of the humerus. So shaft is at the middle. So if you will apply the slab from both sides, then you will be able to support it. So that's why it is a use lab. So you should imagine that how will you support it, then you will not forget about it. Apply with the elbow, flex the netic and hold in place. So that can be also asked. How will you fix the arm in the use lab? In the uh, elbow flex at 90 degrees. Okay, that's also very important. If it displays fracture, neurovascular, if there is any neurovascular complication, anything, any displacement, then you will urgent refer to the orthopedic. In children, you can consider non-accidental injury. So in the radial humerus short fracture of the humerus, there is a radial nerve injury. So that's the end of today's session. I hope you have enjoyed. You can give your feedback in the comments. If any question you can ask.
No doubt, Dr. Khizar, it was a wonderful session, and it was powerful session, I must say. And thank you very much for the session. Each and every topic and each and every point was there in the slide, and nothing was not important there. Everything was important. And thank you very much for the session.
Okay, thank you, Dr. Webb.
Can you just show the 27th slide, the humeral shaft fracture image?
Yeah, you can see that is. I will send the X-ray and about the area. Okay, and whatever I have taught and about the fracture, you must Google it. Okay, and
Thank you, Dr. Khizar. It was a wonderful session. And a lot of things are coming back. Listening to you, just by listening to you. I don't know if there is a tendency with emergency medicine that you tend to forget these things very quickly. And
yes, that's why, Nabil bhai, I mentioned that you must revise the course 3 to 4 times if you want to pass it. And that whatever the high yield topics, you must revise it 4 times, and what other topics you must revise it 3 times. Okay, resuscitation, trauma, toxic, cardiology, ophthalmology, ENT, resuscitation. These are very high yield procedure skill. You can get marks in it. Okay, yeah. Allah Hafiz. You must read it, and either I will tell you, either we will have tomorrow another session. We will complete it. That's how I will send in the groups. Thank you very much. I hope you have enjoyed it.